So, welcome to the Keen on Yoga podcast. Today's guest, again, on for the third time, is Bernie Clark. Welcome, Bernie.
Thank you, Adam. It's nice to be back.
I consider Bernie one of the foremost experts in the yoga anatomy field. And in fact, his book's Your Body, Your Yoga. I think it's a trilogy, Your Lower Body, Your Yoga, and Your Yoga, Your Spine, or something along those lines. Anyway, put them into Amazon. You can find them. Highly recommended. I've read them loads of times, still reading them because I find anatomy hard to understand. But if anything, I've learnt my anatomy a lot is down to Bernie's book, so for better or worse, in terms of my own anatomy understanding, don't put it down to the books. Anyway, on that note, today, Bernie, you're welcome. It's you've done a service to the industry, honestly. But today we're going to talk about my hip. Well, hips in general, but my hip. I've come clean recently and said, look, it's about time for you guys to know that I'm in line for a hip replacement, a bilateral hip replacement, not a resurfacing, the whole thing. Bernie's prompted me on a number of discussions we've had about exactly what's going on. And I realized that there was a couple of details that, I wasn't quite clear of. And also just kind of debunking or going through these ideas now that yoga causes hip replacements. I'm certainly something that has stuck in my head. People have said it to me. All these yogis now are having early hip replacements. So having spoken to Bernie a little bit about that, we wanted to talk a little bit more about that, having a little bit more information. So, the claim that yoga causes serious hip injuries, Bernie, we should start there and your research or your understanding on it.
Yeah, I mean, definitely anything can cause a problem in the hip. Playing sports can cause it. Having accidents, car accidents can happen. Yoga could be a cause, but generally it isn't. And I'll talk a little bit more about why that is. It could make it worse if you have some sort of thing. But maybe just as an overview, let's define what we mean by a hip. Just a little bit of anatomy. Because a lot of people, they put their hands on where the belt is and they say, that's my hip. Or they may reach down the side of the torso and say, that's my hip. So what exactly is a hip? Well, anatomically, we're talking about the top end of the femur. This is called the proximal end, just about where the greater trochanter is and the neck of the femur and the ball of the femur. So if you reach down to your side and you feel that bony bump, that's called the greater trochanter. We have a lesser trochanter on the inside. You can't feel that one. But that part upwards into the acetabulum, which is the hip socket, that's generally what anatomists call the hip. So this is the area that we're talking about here. And there's roughly 6 causes of pain in this region. It goes by the acronym STAIRS. I don't know if you've heard this before, but STAIRS. The first S stands for strains. So we got a whole bunch of muscles here. We have the muscles on the side that abduct the leg apart. That's mostly your gluteus medius. We have the muscle in the back, your gluteus maximus, that can extend the leg. You have in the inside of the groin, the adductor muscles that can adduct the leg. You have the muscles in the front, like the iliopsoas and your rectus femoris, and that flexes the leg. And then we got the 7 external rotators and a few internal rotators. So we got those kind of 6 groups of muscles. If you pull a muscle, that could be a strain. So you might feel pain here due to a muscle strain. And generally, that will resolve itself over a few weeks, just conservative treatment. Don't do anything too fancy to it. The next one is called trochanter pain, which is, again, that big bumpy bone here. This is where your IT band goes. And a lot of runners and people do a lot of outdoor activity. That IT band can get quite tight, and you can compress the trochanter bursa here, and that can cause a lot of achy pain. So for a lot of people, you just got to stretch that out and kind of lay off it for a while, let the inflammation die down. Some people, it's so bad they actually have to have the bursa taken out, but often it'll grow back again. So that's the trochanter pain. Then we get the next one's arthritis. A is for arthritis. The I is for impingement. These are the big ones, so we'll come back to those. So we got the strains, we got the trochanters, arthritis, impingement, and then we have the next R is for referral. If you have back issues, like you've got a slip disc, not literally a slip disc, there's a bulge in the disc, it might be compressing a nerve root, or you got some bony growth or stenosis, and you've got pinching on the nerves itself in your lower back, that may show up anywhere that nerve goes. So there's a big long nerve called the sciatic nerve. It goes from kind of your lumbar and sacral region all the way down to your foot. And if you compress those nerve roots, you can feel a burning in your foot, you can feel an aching in your butt, you can feel pain in your hip. So these are referred pain. There's nothing the matter with your hip, but you feel it there. The sixth one, S, again, is sciatica, or the sacroiliac region. There can be a lot of pain there and some instability. Usually the sacrum and the ilium, these bones here, they're fairly tightly bound together. There's very little movement there, on the order of a millimeter or two. But for some people, especially if you've had a baby and all that got loosened up and stretched out, there's some instability there, which can cause pain in the pelvic region. So those are kind of the main causes. But if we go to the A again and the I, the impingement syndrome, these are the areas a lot of people think that yoga has been causing my problem. So let's start with the I for impingement. Basically, if you think of the neck of the femur, there's the big long shaft of the femur, and then there's the head or the ball of the femur. It's joined with the neck. And then the hip socket itself has got this fancy Latin name for it. It's called the acetabulum, which means vinegar cup, like you drink vinegar out of this cup here. More like a sake cup to me. Well, it's a weak wine. I guess you just drink your wine out of this stuff. So you got the rim of the acetabulum, you got the neck of the femur, and for some people, these two bones hit, and that's called an impingement. If you try to get maximum range of motion out of your hip socket, say an external rotation, you're more likely to come into that point of impingement. But it turns out that most of the impingement happens in the front part of the hip. Now, everyone's femur is different. The angle of the neck of the femur is different. The orientation of the curve of the femur is different. So some people will never get impingement. It's never going to be a problem. Some people very easily get impingement. There's a condition that usually only men, well, mostly it happens to men, about 1 in 4 men have it. It's called a cam. And that's where the neck of the femur, instead of having a nice narrow waist, it gets a bit thicker there. And it always tends to be thicker in the front top part of the neck. So this front part top of the neck, is because it's thicker in about 25% of men and about 14% of women, it leads to impingement on the rim of the hip socket more easily than the people who have that nice waist shape neck here. Those people don't normally get it. On the other hand, the acetabulum has a lip of cartilage here called the labrum. And for some people, mostly women, that labrum can be quite overgrown. It can happen in about 14, 15, 20% of women. Hardly ever happens to men, though. So men tend to have the cam, the thicker neck. Women tend to have this pincer, they call it, the labral overgrowth here. And either case, if you have too much of that, you're going to get more likelihood of an impingement happening. Now, I spent a lot of time playing with the bones and saying, well, how does the bone move? Where would impingement arrive? And if you actually play with the bone and you internally rotate the femur, eventually the front part of the neck of the femur is going to impinge on the front part of the hip socket. That's called FAI, femoral acetabular impingement. Sometimes there's an S on it, femoral acetabular impingement syndrome. So you get that pinching there, and over time, it can start to wear away the labrum, or you can start to crush the cartilage inside the hip socket. All the bones are lined with cartilage. Very slippery thing. So the inside of the hip socket is all cartilage. You got that lip around it, the labrum cartilage. At the end of the femur, you got cartilage. And that lubricates the movement. But if you continually get to this point of impingement, sometimes you can start to crush the cartilage underneath there and delaminate it. Now, not everyone will get impingement. I've heard some yoga teachers warn about flexion. They're afraid that if you do too much flexion in yoga, like lunges, where you always flexion the hip, you're going to increase your impingement.
Yeah.
But if you ever get a pelvis and a femur together, there's no impingement in flexion. You can flex all day long and the two bones won't hit. If you add a bit of internal rotation and then flexion, that's when the roof of the acetabulum starts to impinge on the neck of the femur. And that's when you get the FAI. So it's not just pure flexion, it's flexion with or internal rotation, sorry. And also it can be with some degree of adduction. If you adduct, you actually go away from that impingement. There is a study done in Switzerland that showed who is most likely to get impingement. And they showed that this happens mostly to people who, for genetic reasons, when they're growing up, they had a big cam in the neck of their femur. And these are the ones that later in life, when they're an adult, they get the impingement. People who don't have that big cam never seem to get it. But even if you get that big cam, you also have to do the internal rotation. You do internal rotation and adduction, flexion, internal rotation and flexion, then you can get the impingement. So what poses, here's a quiz for you, Adam. What poses in yoga do we do internal rotation and flexion?
Well, first of all, I'm going to say, if you're listening on the podcast, go to the YouTube video and watch this because if you're anything like me, it's not simple to follow. But answer your question about it. Internal rotation and flexion. I mean, is this something to do with the article you sent me with Michelle Edwards and the impingement of the hip situation?
Yeah. Her and William Broad wrote this thing a decade ago or so that claimed that we're getting a lot of hip replacements because of flexion.
Because
my
of flexion.
Point was, well, it's not flexion; it's flexion and internal rotation.
Yeah. So we'll link that article because it's very interesting, and you can see Bernie's replies, and it will give you a lot more thorough, in-depth ideas that you could ponder in your own time. Because it's not simple. To answer your question about would it be a standing forward fold? Would there be internal rotation there? It's kind of external, really, isn't it? I mean.
Well, yes, no, and maybe. That's one of the answers.
Yeah. It
the
depends
most
how
obvious
you do it.
one is when you're doing eagle.
Yeah,
where you're internally rotating.
Yeah.
Gurudasana, and then you're folding forward. So that is the most obvious case. Or if you're doing Virasana, where you're sitting between the feet, you have to internally rotate to sit between the feet, and then your hips are flexed 90 degrees to sit in there. So those two cases, definitely you're doing internal rotation and flexion, no matter who you are. Now, there are some people, because of the orientation of the hip socket, you were talking before we started about these two terms, anteversion and retroversion.
Yeah.
The average pelvis has a hip socket that you can see when you look straight to the front.
Yep.
That is an anteverted, its version, its angle is forward. But for some people, the hip sockets are retroverted. They're pointing out to the side. And when you look at a pelvis from the front, you wouldn't see the hip sockets. Now, these people, when they stand, their feet are turned outward. They're very externally rotated. And yet a teacher may come to them, they want to stand with their feet pointing out like 40 degrees or more. And the teacher will say, in mountain pose, have your feet pointing forward. Well, that's causing them to internally rotate in the hip socket. That's not the neutral position. The teacher, with best intentions, has taken that student out of their neutral position and internally rotated the femurs to a max, and then they have them do a forward fold. Well, that's the recipe for impingement.
Right.
It's not the flexion itself, but combining that internal rotation for that person. Now, if you have anteverted hip sockets, you don't have to worry about it. You'll never reach impingement because you're not internally rotating your feet. You can stand in mountain pose. Your anatomy is such that is neutral in your hip socket. It feels natural for you to fold forward. But these people that have the external rotated hip sockets, it's unnatural for them. They hate it because they get that pinching in the hip. And at the end of their sun salutations, you notice their feet are out to the side again. And these people just don't listen.
They should have very good external rotation, right?
They have no problem doing lotus pose and maybe bring their feet behind their head because their pelvis is already pointing out that way.
But when is the point in your, I was reading through your book before we came on, I told you, when is the point when the angle of the hip actually is to the side, but it's up? Like it's quite so that instead of the acetabulum being at the bottom, it's to the side, and then you say the external rotation hits the ilium too quickly.
Yeah, that's a different angle. Yeah. This is called version. So there's anteversion and retroversion. The one you're talking about is called the acetabular angle of abduction.
Okay,
that's this angle here. So I'm looking. There's a plane here, and some people it's more vertical, in which case they can easily abduct quite a bit. Some people, it's almost to horizontal. And when they abduct the leg out to the side, the greater trochanter hits the pelvis, the side of the pelvis very quickly. So you can see if I had a very vertical acetabulum, I could move my legs quite wide apart in side splits. If I had more of a horizontal acetabulum, I couldn't move very much before the bones hit. So
Right.
that's another factor. That's an impingement at the top of the acetabulum and the neck here. So
Right.
abduction definitely can get you into impingement. Flexion won't get you into impingement unless you're internally rotating. And if you've got a retroverted hip socket and your teacher's always nagging you to have your feet pointing forward, then you're internally rotating. Now you're flexing. That's when the roof of the acetabulum comes to impinge on the neck of the femur.
Yeah.
So
So,
not
so
everyone is going to be bothered by this, but again, 25% of men do have a pronounced cam, and with internal rotation, they could reach that impingement.
So first of all, what we can highlight here is the massive discrepancy between hip joints, and even I think between individuals. That as you point out in your book, there may be differences between each hip on an individual, but obviously between individuals, huge variation. And where this in Ashtanga considered to be doing the same practice in an idealized form of the posture, and that's when people get into trouble. You should do the posture in this way, and obviously everyone's hips are different. We don't need to point that out
Yes.
anymore. But Bernie,
And your
going
left hip
back,
is not the same as your right hip. So
right?
we're
Yeah,
we're
right.
not symmetric.
Yeah, and also we're always told try and pull the body into symmetricity. That's especially in Ashtanga, there's an idea about the symmetry in the primary series, and you do one side, you do left side, so you try to bring which I've always said is a dangerous idea, trying to pull the body into symmetry when it isn't necessarily symmetrical.
Yes.
So
Yeah.
possible recipe for injury there. But I mean, what is the problem with the external rotation again? I kind of feel that my understanding prior to this was definitely that extreme external rotation, things like lotus posture, things like leg behind the head, would be the most risky postures in terms of causing hip damage.
Well, it could be. Look at the pelvis from the backside. The
Yeah,
head of the femur goes into the hip socket. As you externally rotate, now the back part of the neck of the femur is going to come into contact with the posterior rim of the hip socket. So there you may get impingement if you're externally rotating a lot. But these angles change depending on what you're doing with your pelvis. Here I'm showing,
yeah,
if you're watching this on YouTube, standing up.
yeah,
And there's only so much room I have to externally rotate for these particular bones. Everybody's bones are different. But if I'm sitting, now as I externally rotate, notice I don't hit there. Because of this acetabular angle of abduction, these hip sockets are on a slant. If I'm standing, I hit this part, the back part. But if I'm sitting, the neck of the femur is actually going to the inferior, the lower part, and there's a lot more room to do that. And the more I flex, the more room I have. So if you're ever sitting in a pose like Gomukhasana, cow face pose, your both legs are externally rotated. And some people, they can't get their feet too wide apart. They're not too externally rotated. But as soon as they start to fold forward in the pose, suddenly their feet can come forward because you're increasing the range of motion you have before the bones hit. The more you flex, the more room you have for external rotation. So doing lotus pose, you got more room to externally rotate than when you're doing that standing, what's that, Ardha Baddha Padimoksha?
yeah.
No,
Ardha Baddha
the standing
Padmoksanasana.
up one.
Yeah, which used to come at the end of primary series, which has moved to the start of the standing postures. Unfortunately, because it's a much more challenging posture, should come at the end when you've done lotus in flexion. But unfortunately, it comes
It's a
early
half
now, too
lotus,
early.
but the hips are not flexed. So you actually have less room
Much
for
harder.
that.
Yeah, exactly. Yeah,
So it is true that you will get compression, impingement, the back of the neck of the femur against some part of the hip of the rim socket. But most people who have hip injuries, that's not the problem. I talked earlier about the labrum. You can crush the labrum. You can get a labral tear, as they call it. But that's not always a problem. I mean, by the time you're 40, most people have a labral tear and they don't even know it. It's asymptomatic. There's not a lot of nerve endings in there. So the whole impingement thing, yeah, it could be a problem, but the real problem of impingement is when you're hitting the bones and then you keep going and the head of the femur is now digging into the cartilage of the hip socket. That's the real danger. It's not what's happening to the rim of the hip socket. A torn labrum can be a problem, especially in your 20s or 30s, and especially if you're an athlete. It could be very painful. But as I say, as you get older, most people have these tears and they don't even realize it. What we really need to talk about is the A. So we went through the acronym STAIRS, STAIRS. So the A, the arthritis, this is the big problem. This is when people start to need hip replacements or hip arthroplasty, they call it. Just it could be a replacement, it could be a reinforcement, it could be a resurfacing, lots of different options. So it's really what's causing the arthritis is the big concern.
And first of all, let's just say what is arthritis exactly? Define that.
Yeah, it comes from a Greek word. Arthros means joint.
Yeah.
Anything that ends with the suffix itis, itis, means inflammation. So appendicitis, inflammation of the appendix. Okay? Bronchitis, inflammation of the bronchial tubes in your lungs. So arthritis is an inflammation of the arthros, the joint. So it's a catch-all phrase. It means inflammation of the joint, but it's more than just that. Generally, there's a lot of different causes. The one that we worry about in our field is osteoarthritis, where the bone is hitting the bone and it's wearing away the tissues. There are other forms of arthritis. There's rheumatoid arthritis. This is where the immune system, for some reason, thinks cartilage is bad and starts to attack the cartilage. So the body is destroying its own cartilage. So hopefully you don't have that. But the overuse type of cartilage is arthritis.
You could do tests for that. Yeah.
So there's lots of other ways that a joint can degenerate. But if we just look at the arthritis, one type of arthritis is something called avascular necrosis, which is a word I gather you're familiar with. So if we break that word apart.
My hip diagnosis is avascular necrosis. Yeah.
So necrosis, necropolis means death.
Death.
Yeah. Avascular, vascular is your blood system. Avascular means no blood system. So basically what happens in the head of the femur here, the neck of the femur, so it's not really in the hip socket itself, but there are blood vessels that feed the bones. The bones need blood to get the calcium to build no bone. Running in front of the femur is a major artery called the femoral artery. It sends a couple of little arteries into the bone. One's called the medial circumflex artery, and the other is the lateral circumflex artery. These arteries go right inside the bone, and they feed the bone. There's another one. I don't know if you can see this. There's a little dimple in the head of the femur there.
Yeah.
There's a ligament that goes from the hip socket to the femur, so that you don't pop your femur up. There's actually a ligament holding it together, and there's a blood vessel going through that ligament. So we get these blood vessels bringing nutrients to the neck of the femur. For a lot of different reasons, that blood supply starts to get cut off or weakened. It could be diabetes, it could be too much steroids, it can be alcoholism, and it can be usually it's an injury of some sort. You've had a fall at some point, and those blood vessels got pinched or destroyed. You don't really notice it for the first 6 months or so, then you start to notice a little twinge there. 2 or 3 years later, this whole bony region has decayed. If you look at the x-rays, instead of it being a nice angle between the neck of the femur and the shaft of the femur, it's like this whole thing is swollen up and dropped down, and sometimes it even comes out of the hip socket completely. So this whole tissue there is basically dying. That's necrosis. Once you're at that stage, unfortunately, there's nothing we can do to bring it back. And that's when the doctors will come in and say, well, we're going to have to replace all this.
Apparently the case.
So when you get to that stage of vascular necrosis, unfortunately, and yoga doesn't cause that.
Yeah.
Yoga actually can be very therapeutic for it. In the early days, moving the joint is going to help to bring the blood flow to it. So this is actually less frequent in yogis than it is in the general population because they're moving around a lot. But if you're doing extreme type of yoga practice, contortionism and so forth, where you're trying to go to your maximum end range of motion and then some more, that's when you can start to do too much damage there. So as long as you're playing within your bounds of what you naturally can do, yoga is very therapeutic for this.
And I
If you
think
go
that's the million
beyond
dollar
that, you're
question,
trying to bring
really.
the foot
Yeah,
behind the
yeah.
head. That's
I
okay.
mean, I was speaking to a surgeon in India about it, and he was like, yoga would never have done that. It's very, it's very therapeutic yoga, and I was like, well, I
Mhm.
don't think he'd seen the kind of yoga that I was doing, right? The kind of extreme advanced postures of Ashtanga yoga. He would have said something different. And I think that's the general misapprehension potentially when people say, well, yoga won't damage it. It's like the level of the degree of leg behind the head, putting leg behind the head, putting another leg in lotus, bending over with leg behind, all the kinds of things, you twisting with leg behind the head. That is extreme stress on that joint for someone who has a propensity in that joint already. Yeah.
Yeah, but I suspect he's right in that what you're talking about could lead to that impingement syndrome, which could then lead to the crushing of the cartilage and the delamination of the cartilage. So that type of arthritis definitely could be caused by just too much overaggressiveness. But avascular necrosis probably is not being caused by yoga. I think your
No,
your guy in
I
India
don't
was
think.
probably right. Yeah,
Yeah, no, I don't think it was. I had. Yeah, we can probably rule out alcoholism, steroids. So we're gonna
yeah,
have to
yeah.
go with. So we're
Diabetes.
gonna have to,
Yeah.
yeah, diabetes. So we're gonna have to go with injury. But I don't remember an injury. But yeah, when you look at
Well, it
the
might not be
chart here,
one dramatic injury. It could be cumulative injury, like
yeah,
somebody who's
yeah. I mean,
working a lot
certainly,
in a labor-intensive job. They're
I
constantly
could,
putting a weight
yeah.
strain onto this, and over time that could damage the
It's
arteries.
really interesting on the MRI. You can see this whole dark area. Like there's no blood there. Like the bone is dead,
Right.
and the rest of it's bright. In the MRI,
Yeah.
and there's a complete dark area. Like so, he always said. When I was talking to this guy over quite a period of time, it was very interesting. In India about the hip, he said it's like you're tiling. It's like you've got the tiling, and then underneath the tiling, the concrete's all broken, right? So you can
Right.
tile over that surface, but it's going to be a problem because you've got nothing to really hold it underneath it. So unfortunately, the diagnosis is such that you'll have to have it replaced at some point. But I was holding off for a long period of time, and certainly wasn't doing those advanced postures in terms of yoga therapy for a good period of time.
Right.
But I mean, going back to the original question, can femoral we're saying femoral impingement can then be a cause of osteoarthritis, which will then cause you to have some problem with the hip or possible procedure
Yeah.
necessary. But can the yoga postures, do you think, cause femoral impingement themselves, right? So the cause then is yoga rather than some pre-existing injury or propensity you have. Could you
Yeah.
actually do yourself a danger that would then,
Well, let's not demonize any movement. Impingement is
mm,
okay. We need
right,
to have the bones hitting the bones. Cartilage
right.
only grows stronger through compression.
Hmm.
Different tissues react to different stresses. Our muscles, our tendons, our ligaments, they react to tensile stresses. So if
Yeah.
you put a stress into them, like pulling on a spring or elastic band, that's how they get stimulated to grow thicker and stronger and longer. Cartilage only gets turned on when you compress it. So you compress the cartilage, leave it alone, compress it, leave it alone. This stimulates the chondrocytes, the cells that live in the cartilage, to turn on and make the cartilage thicker and stronger. Bones can be stimulated in both directions. Bones can be stimulated through compression, but also through tension. Like if I bend a bone, then I'm going to increase the strength on the outside end of the bone. If I compress the bone, I'm going to increase the strength in the inner bone. So bones are kind of unique tissue that they grow thicker and stronger through both types of stresses. So we need to stress the bones. We need to have impingement. That's not a problem. Every time you take a step, the head of your femur is pressing into the cartilage of your hip socket. That's good. You need that. Walking is very healthy because that's stimulating the cartilage to grow thicker and stronger. But like anything, you can do too much. So think of it as the Goldilocks rule. Remember Goldilocks and the Three Bears?
Yeah.
Some porridge was too hot, some was too cold. You want it just right. So moving your leg through its full range of motion is not a problem. Overdoing it under high stress loads, where you're just continually damaging a little bit, you need a lot, you don't need. So the people who are type A yogis, a Ashtanga maybe in this case, yeah, they tend to overdo it, and that could cause catastrophic impingement. But again, it's not the impingement necessarily that's causing the problem. That would affect the labrum. It's the crush underneath here that starts to break apart the cartilage, and you're not giving the cartilage a chance to regrow and recover. So that definitely could happen. That's a different type of arthritis. It could still lead to, in this case, probably a resurfacing of the hip socket.
Right.
So definitely some people can do too much of that. We should maybe back up and talk about, are more yogis needing hip replacements these days than in the past?
Yeah, I was
I
going to
think
come on to
there's a
that.
lot
Yeah.
of confusion between causation and correlation.
Yeah.
To understand that, we have to look at, in the past, let's say 20 years ago, if somebody had to have their hip replaced, they would get maybe a steel implant here. Now, hip replacement is carpentry. The surgeon goes in. They used to go in from the backside, so they cut away a lot of the
Muscles.
gluteus
Yeah.
maximus and the ligaments in the back that restrain certain movements. And they'd get the hammer out and they'd saw off, cut, like a carpenter. They'd saw off the top of the femur, and then they screw in a metal piece there. They would tap in or glue in a metal piece on the side of the pelvis, and then they would line the pelvis with a bit of plastic. And that technique would last 6, 7, 10 years.
How is that? Oh,
you could only do that twice
yeah.
because everything would be so destroyed you couldn't do it again. So generally, they only allowed hip replacements to be done to people in their 70s and 80s because they probably going to not live as long as this thing would last. But somebody in their 60s and 50s, they would outlive their prosthetics. And you can only do this once or twice, and so you would be bedridden for the rest of your last 20 years of life. So we didn't do hip replacements for younger people back then. But today, we would put a titanium plate in there, and we got some good new plastics, sometimes ceramic, but it's a high density plastic that never wears out. I mean, these hips today can last 30, 40 years. And if you do that twice, no, it's going to last you the rest of your life. So today, we don't have to worry about it. Plus, the surgery itself, we go in from the front, and it's minimally invasive. We don't have to destroy all the capsular ligaments.
Or the side as well. You can do a lateral.
Yeah, it's not coming from the back.
Yeah, or it can do. It can. They do still do the back. In certain cases, because they say it's the argument is that it's less chance of hip displacement. Out of the joint again. So they do still do the back, but the anterior is what people often favour, or the side as well. They say it's because it's minimally invasive. It's tissue sparing. Like they say. Yeah.
It depends on the surgeon and what exactly he's going to do. He'll tell you what you need. But the thing is, because these last so long now, people in their 50s and 60s can now get a hip replacement. Whereas before, you just wouldn't be allowed. So now this surgery is available to a younger group of people. So is it the fact that people are getting more hurt? No, it's the technology has now come down so that it's so much easier to do this. And more people are doing it. People in their 40s are getting it because it can last 30, 40 years.
Yeah.
And then you can repeat it again.
Yeah, a very important point to be made. Yeah, because it is a very changed playing field. When they say more people are getting it, well, exactly, that's why. And still, though, I think that even among surgeons, that idea exists. That they were saying to me similarly, we don't want to do it too early. You're a little bit young. These last 20 years, then it's hard to replace again. So I think there is still this mentality, because obviously, just like anything else, there's different information to different surgeons. They only have their own opinions. Then other surgeons will say, there's no problem. You can have it replaced numerous times. There's no, we can do this numerous times. So there's definitely still a multitude of different opinions out there. So if you are listening to this, then at least go and see a couple of different people and have different opinions on this. Because certainly for one person, I was told we need to go in from the back. And I've done my research, obviously, and I was like, well, I don't want you to go in from the back and cut through certain muscle tissues. That seems like a really bad idea when one can just go in from the front. And they were completely impervious to reason on that one, right?
Well, part of it is where you get it. Part of it is where you get it done. The going in from the front is more expensive technology. So I'm in Canada. Some of the hospitals here don't have the new techniques. They don't have the new equipment yet. Right, so they still only have the go in from the back part. Right. Now, I'm dating myself. Maybe it's not the case today, but 5-10 years ago when I looked at it, a lot of hospitals only did the posterior one because that's the equipment they had, and that was the training they had. But now, if you go to the more elite centers in the U.S., they'll almost all come in from the front or something that's more minimally invasive because they can do it
as well. Yeah.
Yeah. Kind of and their titanium plastic stuff lasts 30, 40 years.
I think it's a titanium replacement, and a ceramic cup, because they can do different versions of these kind of things as well. And
Yeah, there's different byproducts, like steel would create ions, and
still
those
sounds
ions would create free radicals, which was
right.
bad. The cheaper plastic, the plastic would break off and get into the immune system and so forth. But today, the more advanced plastics are even better than ceramics. But your surgeon will give you the best idea. But depends on where you go. If you're going to San Francisco, you're probably going to get one view. But if you're going to, I don't know, Ulaanbaatar in Mongolia, you're probably going to get a different option.
Which is very true. I'm really unfortunate. A general kind of point about healthcare really is that it's still an elitist system. You know, it depends on how much money you've got in terms of getting the best situation you can, which is unfair, obviously. But the other thing is that when you go in, I mean, I've had this situation with my wife as well on a particular occasion. You go in and you respect their opinions. The doctor or the surgeon, they're so authoritative in that position that you as a layperson feel like, well, they must know, you know, and they're so sure, right? You know, so you really, and I suggest, of course, they know more than we do, but you're still worth questioning opinions, because they do have different opinions. And having, you know, had the situation, as I say, in other occasions, and had a lot of appointments with surgeons, etc., you find that, it's best not to just go, we'll trust that straight away, but go to have different opinions, because there are very different opinions on these things. And I think that's really an important, point for anyone listening.
I think
to do your research as well. Yeah.
In a previous discussion, I think I talked about flying lessons, and you're flying the plane. All these doctors are ground control. They may know more than you about an airplane and even how to land it, but you're the one in the plane. You're the one that's going to crash if you don't do it right. So getting lots of different opinions from lots of knowledgeable people, but you have to decide what you're going to do, because it's your plane. He's not on the plane with you. If it goes wrong, he's maybe a great guy, or she may be a great doctor, but no, they're not on the plane with you. So you have to take responsibility for your health there.
Yeah, I was going to say, backing up on the level of where does it hurt? Can you say, like, can you give any kind of qualifications about certain postures hurting in terms of where you might have done a damage, or is there anything like that? I mean, for me, for example, femoral rotation in something like a straight leg uttanasana. Now, I mean, I know you talked about that on the article that we're linked with, the broad article with Edwards as well, when you're talking about forward folds, and it was very interesting to me, this idea about forward folds with straight legs or bent legs. Now, for me, doing a straight leg forward fold now would involve a femoral rotation of the joint, which would be excruciatingly painful. So I'd have to keep my legs bent there, for example. I know I'm kind of going off point there, but it was just an introduction really to, where, if there's certain pain in certain postures, does that indicate certain places that the joint of the acetabulum might be injured, right? Or if you've got leg behind the head, you try to put the leg in lotus, or, can you say front or back, or can you say anything more about the subject?
Yeah, that's one of the clues the doctor will use to diagnose you is, well, where does it hurt? And they'll also palpate and push to see if it's a tender area. Again, the side of the hip, that could be a trochanter issue. If it's in the buttock itself, that could be a sacral issue, or it could be piriformis. If it radiates down the leg, that could also be some referred pain. So they will look at the pain. If it's more in the inner groin and you're kind of grabbing the front here, that would tend to designate more in the hip socket itself.
Right.
Knee pain can be caused by hip stuff. An interesting thing is when somebody gets really worn out and they might have a talus problem, a knee problem, and a hip problem. Maybe they're an athlete or a runner. Which do you replace first? Well, generally the advice would be fix the hip first, because it's easier than the knee. And once you fix the hip, maybe the knee problem goes away. So don't start with the knee and then work your way up. Start from the core and work your way down. So the pain can be diagnostic. Where it gets tricky is if it's referred pain. It could be something in your disc or your lumbar spine. There's a bone spur. It's right on the nerve root, and you're feeling it in your leg, but it's actually coming from the back. So what the doctors will do is they'll try to provoke the pain. They'll do a few tests. Like one's called a slump test. They'll just have you sit in a chair and slump over. Bring your chin to your chest towards the thighs. Does that increase the pain? Well, we haven't really changed the flexion of the hips here. We're just rounding the spine. And if that increases the pain, chances are it's discogenic. It's coming somewhere from your lumbar spine area. If that doesn't cause the problem, then they may try one's called FAIR, FAIR, which stands for flexion, adduction, internal rotation. So you'll just cross your legs over. Sit down, cross your legs over. Does that make it hurt more? If it does, maybe that's a sciatica condition. There could be something in the sacrum. So they'll do some things to try and make it hurt, and that will give them some clue as to maybe where the cause of the problem is. They'll also look at the time of day. Does it always hurt? Does it only hurt in the morning? Does it only hurt in the evening? That can also be diagnostic. So there's a lot of things the doctor will put you through to figure it out.
Pain always seems to come more in the nighttime. I think for so many things, the body's trying to kind of like repair itself, right? So if anything's okay in the day, or maybe just like you're less focused on pain when you're doing stuff in the day, but when you're at nighttime, you're lying down. Oh,
yeah, you might be more inflamed at the end of the day too, so things swell up a bit more.
That's true. Yeah. I know that there was a particular point in that article that we referred to about you said you were telling the person you were talking to that it wasn't about the hip when she was talking about forward folding and flexion. But can you go through that a little bit again? The idea of the straight leg. I think what the argument was that straight leg forward folds were dangerous and should be avoided, and you were suggesting not. So.
Yeah. Well, the whole discussion, there's a few other articles that preceded the one I sent you. But William Broad came up with this book a long time ago about yoga hurting the body. And he was saying too much flexion. And Michelle Edwards was kind of saying the same thing.
That was his fundamental point, was it? The Broad's, I mean, we'll reference William Broad's book, but that was his fundamental point of the book. You think too much flexion in yoga is a problem?
Well, no, I wouldn't say it was just that, but that was one of the things he mentioned.
One problem.
His main point was that yoga was causing damage. And I can agree that yoga can cause damage. I don't think it necessarily will cause damage. So my point was, let's not demonize movements because we're designed to flex. You look at people in the third world, primal countries, working in the rice paddies, they're flexed all the time. And their spine is rounded and they spend hours and hours a day. But they're used to doing that. So this is a natural human movement. Let's not demonize it. But if there's pain, if there's a problem, let's be careful. So the point was that flexion was causing all these problems. It was causing hip replacements and impingement syndromes, and there were citations of all these yogis, senior yogis, who were getting hips replaced. So I thought, okay, well, let's check. I'll call them. So I called up about 5 of these yogis and said, do you think that your hip replacement, first of all, did you get a hip replacement? Except for one exception, they said yes. Do you think yoga caused that? And they all got very upset and said, no, definitely not. In the case of like Beryl Bender Birch, she said, I think she was the one that said it, she was in a car accident in her teens and yoga saved her hips. It delayed her hip replacement by like 10 years. So yoga did not cause that. So maybe it was avascular necrosis and it was just going to eventually work its way through. But because she was doing her yoga, that kept the blood flowing long enough that she was able to get around it. So again, correlation is not causation. Just because a lot of yogis got hip replacement doesn't mean that yoga caused the need for the hip replacement. It may have delayed it. So then we come back to, well, does flexion cause impingement? And the study that both William and Michelle cited, the Swiss study, didn't say what they said it said. It said with internal rotation and a cam, then impingement would be caused. So that was internal rotation with flexion for these people who during their youth had that genetic predisposition to a cam, they would get impingement. So I'm saying, so 75% of the people don't have a cam. They're not doing internal rotation. Like when I'm doing a mountain pose to a forward fold, Uttanasana, I'm not internally rotating my feet. Now, some people do have to internally rotate their feet because they got that retroversion of the hip socket. So I'm not saying it can never happen. I'm just saying, by and large, this just pure flexion is not going to lead to impingement. If you add other things to it, it could. So that was my point. But then she started saying, well, flexion is bad because of the spine. And I said, well, that's a whole other argument. But she kept going there, and I said, well,
it's a great, and it was a great little debate in the comments. And one of those things, it was like, the comment, but it was, the back and forth was good. And you're saying, well, you've written 1,500 words here, and I'm not even talking about the spine. I'm talking about the hip. Right? Why do you keep talking about the spine? very funny.
So if we want to talk about the hip, the spine, fine, let's go there too.
Yeah,
But again,
but I
it's
think
like everything else. The spine needs to be flexed. Let's not demonize flexion. We do it all the time.
and it also depends on
But
what
for
you're
some
doing. I
people,
mean, yeah. I mean, it depends on what you're doing. You could go forward with a flex spine in a forward fold, or standing forward fold or seated forward fold. But I mean, like looking at people doing deadlifts. Now, I originally would have thought that that would be good to try and flatten the curves of the lumbar spine, but quite the opposite. They do the very opposite, right? They're keeping that lumbar curve in place very much.
they're not flattening it or increasing it. They want to keep the neutral spine. Now, here's a mistake that a lot of yoga teachers make. A straight spine is not neutral. A straight spine is as far away from neutral as you possibly can get, because the lumbar spine has a curve called lordosis. On most people, it's about 30 degrees or so. Some people have a little bit more, it might be 39 degrees. Some people have a little bit less, might be only 10 or so, but everyone's got a lordotic curve there. And that is the neutral position. That's where there's maximum contact between the top vertebra and the bottom vertebra. The bones have got the biggest surface area connecting to each other. As soon as you flex the spine, you're reducing the surface area contact, and you're putting most of the stress to the front of the disc and the front of the vertebrae. So with a straight spine, and if you feel your lumbar spine and it's flat, it's fully flexed. The lumbar spine will never go past straight. So as soon as you put your hand in your lower back and you feel it straight, you've now fully flexed your lumbar spine, which is the worst time to put a big load on it. But we're designed to fully flex our lumbar spine. Now, Michelle quoted in that article, or in her comments, Stuart McGill. So I called Stuart. And Stuart, I've done a lot of time with Stuart. He and I have done a video together on the spine. He wrote the introduction to my book, Your Spine, Your Yoga. So I know him fairly well. And I had a feeling he didn't say what people said he'd said. And he complains about this all the time. He's quoted out of context. If you ask Stuart, is it a good idea to do X? He'll always say, it depends. You can't give a blanket yes or no. It depends on the situation. It depends on the person. It depends on their anatomy. It depends on how old you are. Have you had an injury, a condition? So you're never going to get a black or white statement that always bend your knees, never bend your knees. It depends. We're designed to be able to fold over and pick up our baby from the floor. A lot of people think bending the knees is a guarantee of preventing flexion in the lower back. But Stuart shows in his books, he's done a lot of tests of people picking up something in a workplace, like picking up a heavy box, and they know they have to bend the knees. So they bend the knees, pick up the box, and then Stuart takes a picture at that moment, and their back is completely flat, even though they're bending up the knee. So just bending the knees is no guarantee that you're going to keep the lordotic curve, because people think, oh, I just have to bend my knees, but now they flatten the back, so they're still putting a big load on a flat back. So if you're deadlifting, you want to make sure you've got that lumbar curve there. A lot of weightlifters have to wear wedge shoes because they can't squat. They can't get their heels all the way to the floor. And if you can't get your heels all the way to the floor, you tend to round your spine. So you wear the wedge shoes so that you can keep that lumbar curve.
Stand on wedges as well.
On blocks, yeah. But professional weightlifters, they use the Olympic wedgie.
The wedge. Do they? That's interesting. Yeah, I mean, it depends on what you're doing and how you do it. And it's not as simple as all that, really. But going back to the article thing, I think it's important to say that, you know, when you looked at that article and picked it apart and what was said, there was like some serious problems with what was said. So I mean, you've written another article on how to critique articles, I think, right? Like, which is
caused
really
me to write another article on that.
Yeah, which is really relevant because I mean, we phoned up. I mean, Dharma Micha never even had a hip replacement; he had a knee replacement due to an accident he had in the Brazilian Air Force. So I mean, it just goes to show that when you're reading things like Broad's book and William Broad being a great journalist, you read it, it makes sense. It's like, okay, yes, that's it, you know. And actually, when you look at the stats or look at the studies, there's a lot of cause for questioning. You know?
Yeah, and I got to give, you know, I'm not critiquing William. I think it was a great book. I really enjoyed it. And Michelle's a wonderful teacher. She's helped a lot of people. So I'm not saying, oh, she's a bad person for saying this. I just disagreed with some facts that she presented.
Yeah.
And in the world of science, we're allowed to disagree all the time. You just make your case with your facts. They make their case with that facts. I think they both had the best interest of their readers and their students at heart. So I'm not critiquing the people at all. I just disagree with a couple of their points.
Yeah. This is great. This is the whole point of the podcast in the first place. Just like discussion, and we all learn out of that. What do you reckon about general diagnosis? Someone said in my comment which is I thought was interesting when I posted something about this situation of my hip. Why don't we all have diagnosis like MRIs when we're young, and then we can know whether there's femoral impingements, and then we can act accordingly to that? Which I thought, first of all, never thought of that idea. But second, I thought, well, you talk a lot about fear mongering in yoga, and I think it's now. What do you think about that? Do you think they would actually just cause fear? I mean, kind of, is it helpful to know? Yeah.
I can give you an anecdote. There's another guy in the spine biomechanics community, Serge Grakovetsky. Now, Serge came into this community from the physics background. So he used a lot of his physics knowledge into spine. And I remember talking with one time, and he held up an x-ray. And he said, okay, now here's our x-ray. Can you tell me, is this person alive or dead? It can't even tell you that basic information. So all these imaging things, we have to take with many grains of salt. I mentioned that by the time you're in your 40s, most people have a torn labrum and they don't notice it.
Yeah.
By the time you're like, I think one of the studies was they had men who were over 43 and men who were under 43. And the men who were over 43, 1/3 of those men had a torn meniscus and they didn't know it. In the spine, this statistics, it's easy to remember because of the little pattern. 30% of 20-year-olds, when you take an x-ray of their spine or an MRI, 30% of 20-year-olds have a bulging disc and they don't know it. They're asymptomatic. 40% of 30-year-olds, 50% of 40-year-olds, 60% of 50-year-olds, 70% of 60-year-olds, 80% of 70-year-olds, and 86% of 80-year-olds have a bulging disc and they don't know it. They resolve by themselves after a year or so. The bulge kind of gets dissolved away. So taking an image doesn't tell you anything. It can't even tell you if you're alive. So just because you've got a certain morphology showing up in the image doesn't mean it's a problem. But it can scare people into thinking they've got a problem, and therefore they'll correlate, oh, you've got pain, look, there's a bulge in your disc, let's take the bulge away. Now this happened a lot in the 1950s and 60s. It used to be people who suffered sciatica. They'd go to the doctor, they got this radiating pain down their leg and in their butt, burning sensation all the time. They get an x-ray, they got a bulging disc, okay, they do a discectomy, they take away the bulge. And about a year later, after all the recovery, everything's fine. But then in the 70s and 80s, they started realizing most people have a bulging disc. It doesn't mean it's causing the sciatica. It might be causing it, but it could be a piriformis thing or something in the sciatic, the sacroiliac joint, or something else happening inside the buttock itself or the pelvis. So just because you've got a bulging disc doesn't mean it's causing the problem. So just having an image by itself is not really that diagnostic. You have to use it with all the other things, like the provocation. Let's try to make the pain happen, see what's causing there. And if it is discogenic, let's see, it's only if the bulge is actually going in a certain direction and it's compressing one of the nerve roots. Or maybe the little bony holes where the nerves come out, they're getting smaller. It's called stenosis. Or there's a bony growth called an osteophyte, and that's compressing the nerve. Some of those things might show up in the imaging, but other things might show up and you can have stenosis and you feel fine. Other people have stenosis and it's definitely the cause of the problem. Imaging is one tool, but it's not the only tool.
Yeah, and important to make clear, that doesn't necessarily look. I mean, I think it can easily kind of almost be like a nocebo where you feel like there's a problem, so then you're overprotective, or perhaps you don't even stress that area because you worry about it, and then it weakens because you don't actually use it. I mean, I think again, to go back to your analogy of the Goldilocks principle, it's a question of, well, you've got to move, you've got to be dynamic, because that's a problem if you're not. The worst problem, but obviously dynamism, causes problems as well, depending on pre-existent propensities. I had another question for you. Oh yes. So the situation with my hip is that because of the avascular necrosis, the hip is feeling weak, the whole joint is feeling weak. in itself, not I'm feeling. I'm,
Yeah.
and it's created, yeah, and the bone itself, looking at it, it's created a like it's not round anymore. It's created a lot of these flat little bits to try and bear the weight. Because if you imagine,
Yeah.
obviously, the situation, there's a weight straight down on it, and so at the head, if it's not strong, then it kind of tries to disperse that weight by kind of
Yeah.
creating this more square kind of hip joint, and that causes a lot of pain because it's not moving freely anymore.
Yeah, what's happening with the necrosis, that means the calcium in your bone is not being replaced because the
Mm.
blood is supposed to bring the calcium back. So the bone is getting softer and softer. It's becoming like cartilage, so it can be
Mm.
deformed. So now the weight of your hip socket is pressing onto it and it's deforming all this. This is why it tends to start to drop down here. You might start to notice one leg is shorter because
Oh, so so
there's
it's not
this
doing it
angle
as a
here.
right. Yeah,
So
it's
the
not
whole
doing it
bone
as a
is kind of,
reaction to try and make itself stronger, but just like just the simple weight of compression on it because it's not strong is happening, making that happen.
yeah, it's getting remodeled over time because
Right,
there's not
right,
enough
right, right.
calcium in there.
Why would it make the muscles around the leg feel so weak? I've got no strength to say like walk up a hill with that right leg, like none. Why
I
is
can
that? Why should
speculate.
that be?
There's a
Yeah.
couple of things. One is um, there could be a neurological damage happening here too. So
Mm.
all this decay and inflammation could be compressing nerve roots or things that innervate the muscle groups. So your just muscles aren't acting as well. The blood flow can also be cut off to the muscles, or more likely, I think that the leverage is no longer there. Like if you have a long lever, it's easy to move something. If you have a short
Right.
lever, it takes much more work to do it. I mentioned this little bony bump here called the lesser trochanter earlier. The
Mm.
one you feel on
Yeah.
the outside of the hips called the greater trochanter. Some people, that lesser trochanter is actually quite far down the shaft of the femur, and that gives a lot of leverage. So when your iliopsoas tendon hits here, and you have to lift that leg up, what's that called? Uh, Padangusthasana C or something like that. You lift the leg up and you keep it there. If
Yeah.
somebody's got a very low situated lesser trochanter, they can keep that leg up all the time. For me, I could be able to get the leg up to horizontal, but it could
Right.
be that I've got a very high one here and the leverage of my iliopsoas is just not good enough. It's not that my iliopsoas is weak. It's just that the lever arm has been reduced. So now you're changing the whole architecture of your hip socket, and where your muscles are attaching here, you may not be having the same amount of leverage that you had before.
Hmm.
And it could be a
Right.
combination of all of that.
Yeah, it's a really curious phenomenon. I don't think anyone's given me a satisfactory answer yet. I'll bear that in mind. Why? There's no power in
Well,
the leg.
when they replace it and they put that angle back and you get the
Yeah,
right uh,
right.
orientations, you might find,
Apparently there
oh,
will
now I
be.
got my power
Yeah,
back.
no. Apparently, the muscle will be stronger again, or can be trained to be
Yeah.
stronger again. So, to that end, just to wrap it up, do you know anything about? I mean, people are going to be listening to this that are obviously particularly interested if they have an issue already, an injury. Do you know anything about recovery? Recovery times or anything to avoid, or any ideas about recovery at all that people might be thinking if they were thinking about having a procedure done, a hip replacement, resurfacing? Yeah.
Well, the general rule of thumb is whenever somebody comes into my yoga room and
Mm,
says, I just had a hip replacement, I always default
mm.
to what did your surgeon say? Because the surgeon's
Yeah.
the only one that knows what they actually did in there.
Yeah.
They may
True.
tell
True
you what
enough.
they
Yeah.
plan to do, but once they
Mm,
open you up, all the plans may get thrown out the window because, okay,
mm.
this isn't quite right. He'll have a range of prosthetics. He's going to find the one that hopefully he's pre-ordered the right ones, but once you get in there, you're going to notice it's not quite the one I wanted. I'm going to use B. I can use the B one. So she's the only one that knows what she did. So she will tell the physical therapist who will tell you, okay, here's what we're going to do. So I always start by asking, what did your physical therapist say? Now, with the modern techniques, recovery from a hip replacement is amazingly quick. I mean, there's going to be post-op pain for the first couple of days. You'll get some uh, NSAIDs, some steroid, non-steroidal pain killers and anti-inflammatories. But after a couple of weeks, I mean, you'll be walking that day, and you might have a
Mm, mm.
walker for a couple of days, or maybe up to a week. But after that, you'll be kind of walking around. It may take 3 months until you feel kind of normal again, but that's amazing. 3 months and you've had a whole hip
Yeah,
replaced.
absolutely. Yeah, yeah, yeah.
One
And
caution, you're going to have metal put in you. when you go through airplane security, you will forget that you've had this operation. And it may be 5 or 6 years, and they're going to say, "Oh, you got some metal in your pocket." No, no metal. No, you got some metal in your pocket. And you get into an argument with the guy, and then you're like, "Oh, yeah, I had hip replaced. I forgot because I got some metal in there." So you're going to
I
be
think you get a
firing off all
card
the
or something, don't you?
detectors.
I think you get a card to
If you
carry, and you
remember
can
to
show
show it,
them
yeah.
yeah,
Yeah.
what about
So the
people worrying
recovery
about
is pretty quick.
can they do their old yoga again? And accompanying that, how do you call it? Dislocations, hip dislocations. People really worry
Well,
about
in the
that.
old days, when you came in from behind, the
Mm,
key was to never cross the midline with your leg, and
yeah,
don't do internal rotation. Because what happened
yeah,
there was they were severing the back of the capsular ligaments, and that was what prevented you from internal rotating too much or adducting too much. But now those have been severed. So if you do too much of that, you could pop the head of the femur out of the hip socket. But today we don't do all that major cutting of the capsular ligaments. So you don't have to worry about that. You won't get these restrictions like in the old days, or never cross your legs, or never
yeah.
internally
That's what they
rotate.
say. That's what it says. Yeah,
So
yeah.
now with the new techniques, you can do all that stuff. If you couldn't put your foot behind your head before, don't try to do it now.
Mm,
So
mm.
you'll probably have similar range of motion to what you have because the prosthetics will be similar. They're going to try to make your angles pretty much close to what you have now. But forget the type A yogi stuff. Yoga is going to be great for you. Gentle movements, moving the joint through its 6 degrees of freedom, but don't try to go for a new world record. That's not the point. You're not going to get the 4 series. Forget it. Just you want to be healthy. Your intention is just to be healthy.
Of
So
course. Yeah,
move
yeah,
it, stress it,
yeah.
not
Yeah.
too much, not too little. But yeah, yoga will be great for you. It is recommended after hip replacement.
All right. Thanks, Bernie. I think, no plans yet. So I'll give it a couple of years anyway. Well, thank you for coming on. We'll put a few notes in the show notes to reference what we've been talking about. And yeah, been a pleasure, Bernie. Third time podcast. Please listen to 1 and 2 that we've done together. Bernie's trilogy of podcasts from Akira and Yoga, as well as his books. Get the books. I mean, they're totally possible to read as a layperson. The second half of them, I believe, is a bit more technical, but the first half is always very, very accessible, excellent information. So please use Bernie's resources that he's very helpfully put out there, and I look forward to speaking to you perhaps after I've had it done, and let you know how the 4th series is coming on. Yeah.
Well, thank you,
Thanks,
Adam.
Bernie.
It's great to be back, and good luck with the procedure.
Thank you.
गणपतये नमो नमः श्री सिद्धि विनायक नमो